antibiotic, it's the rate at which they're becoming ineffective. So ciprofloxacin, which is going to be this bar right here on the top, we're seeing is really skyrocketing. It went from 3 to 17% just in a single decade. TMP-SMX is the next one on the line, the dashed black line, and it was already high at 17.9%, and that's still increasing over time. And this is showing us a national average, but local resistance varies across the United States, and actually the western states have the highest rates. So singular resistance is becoming very common, but now multi-drug resistance in UTI is emerging. And so extended spectrum beta-lactamase enzymes, they basically cut up the antibiotic and prevent it from being able to do its job. And these have become an emerging threat. So when you're these can't be treated with TMP-SMX or Cipro. And these have always been a concern for hospital-acquired infections, but now we're seeing this actually in community-acquired infections. And so this is a completely new danger for uncomplicated urinary tract infections. And so when prescribed antibiotics don't work, patients are having to receive the last resort antibiotics, so carbapenems. And when they don't get that fast enough, they're going to end up with bloodstream infections. This will lead to hospitalization, a lot of costs, and mortality ultimately. And so this is what we're talking about when I say collateral damage. And so these are all of the impacts like selection of drug-resistant bacteria, making an individual more susceptible for colonization of an antibiotic-resistant infection. This can also be someone who didn't have a bacterial infection that was treated, now having unnecessary exposure to antibiotics, as well as secondary infections, so a yeast infection that might come once you've completely wiped out your microbiome. And one example of how this occurs is with quinolones, which I mentioned before, and these are not recommended due to their propensity for collateral damage because of their effects on the microbiome. And so as time goes on, one UTI at a time, every new exposure to antibiotics adds up. And now in our country, nearly a fifth of infections are resistant to these drugs. We've lost the effectiveness of them. And the United States is not an isolated community. Reckless antibiotic policy across the globe in developing countries, this can cause global threats, spreading infections, so that we're to a point where we're using our last resort antibiotics. I like to think of this as no single raindrop believes it's responsible for the flood. And what that means is the negative impact of waiting to treat these infections means that it's beneficial to go ahead and prescribe antibiotics without having these lab results in. And so that's the concept of empiric prescription. And so this is considered cost effective when it compared to not treating the infection at all and waiting for something along the lines of directive treatment. So directive treatment is diagnostic based, like using point of care dipsticks to test for indicators of an infection, running cultures to test for resistance. And because UTIs are painful, starting treatment immediately is a chief concern among practitioners and patients. And so empiric prescription is going to be reducing symptom days for most patients. Now, while cost effective, empiric treatment is a bit like a guessing game, and it has propensity to fail compared to other diagnostic tests. And so although it's cost effective, it's also the least effective strategy. And recently, the chances of UTI will be resistant to one or more antibiotics has been on the rise. And so to increase the odds of success, doctors need to use previously reserved, stronger, more expensive drugs. Because they're more expensive, it's still actually balanced out though, because it costs a lot more to treat a kidney infection or when somebody's hospitalized. And so this is what had me thinking about what kind of costs are going into this decision making to say, let's use the stronger drug, and whether or not we're really considering collateral damage and whether multi-drug resistance or any of these super bugs are really being considered when we're deciding how to treat UTIs. So to start to answer this question, I did a systematic literature review. I wanted to review all the studies that are out there for uncomplicated urinary tract infection and see how much resistance was costing to treat. These concerns have been around a long time, as I mentioned, for hospital-acquired infections. But since this is a newer threat, I wanted to focus exclusively on community-acquired infections. And my objectives, I wanted to review the literature for rates of treatment failure, whether they were being prescribed empirically or using directive strategies. And since cost-effectiveness was so important, I also wanted to see how these costs were being accounted for in these analyses and comparisons. So just knowing that collateral damage was such an emergent threat to common infections, it seemed really important to investigate whether these threats were properly being accounted for in clinical decision-making. So I used a PICO statement from the navigation guide opposed to the PICO's statement from the PRISMA standards. And for those of you who don't know about the navigation guide, it was a recently built tool out of UCSF to systematically review environmental health research questions. It combines important elements from nationally recognized protocols for systematic review, but adapts them for environmental health. So my participants, females that were being prescribed antibiotics, they had a UTI, and then I was comparing people that either had a resistant versus a susceptible infection, and then looking at what were the rates of treatment failure or the risk of treatment failure, and how much did that cost, if they were including the cost analyses broken down between the two comparisons. These are the search terms. This is a simplified format for the presentation, but I basically chose these words based on being in the buckets of resistance, urinary tract infection, economics, and empiric prescription. Another feature from the navigation guide that I used was this assessment for the strength of the evidence, and that involves assessing all of the studies for risk of bias, condensing that down into rating the quality of the evidence, and then rating the strength of the evidence. We'll get more into that in my results. Moving into results. So I searched PubMed, Medline, Scopus, Web of Science, JSTOR. I found some records from other sources, ended up with 606 non-duplicates. I applied some exclusion criteria and removed about 500 titles and abstracts. These were related to maybe they were just surveillance or they were looking at risk factors. They weren't comparing a resistant versus susceptible, things along those lines. From the 93 I reviewed, eventually I found 16 that met my PICO statement. So now going into the results, I have it broken down by the resistance profile. So these are the results related to infections patients had that were resistant to TMP SMX compared to someone who had an infection that was not resistant to TMP SMX. And so what we're seeing among these 4 studies is that the risk of treatment failure, which is what we're seeing right here, or the percentage of treatment failure, that was comparing the two, is seeing just higher rates, significantly higher rates, with non-overlapping confidence intervals. And we're seeing that for bacteriological, so whether or not when they did a follow-up culture, whether that was cured or just symptoms alone. And so, these include things like still having pain, being out of action, and that has to do with, lost productivity. So it was really nice to actually see these among many different types of treatment failure, the way it was being measured, that we're seeing this very consistent result. Moving on to just any antibiotic-resistant E. coli. Again, very consistently, we've got an increased risk, whether that's through an odds ratio or just a comparison of the two groups. And then also looking, many studies, because the ESBL producing E. coli is an emerging threat, many studies also included that in their analysis. And so in these, it's a little bit different than the uncomplicated UTI. More often we're seeing this as like a bloodstream infection. And so that's why we're seeing these increased severity in that it's mortality, not just having flank pain. But again, an ESBL producing E. coli has a much, much, much higher risk of dying than one that's not. And so just to sort of plot what I could that was comparable odds ratios, I made this little forest plot. And again, we're just seeing very consistently above 0. Confidence intervals are not including anything underneath 1.5 even. And while we do see pretty tight confidence intervals on this guy, these just have a smaller sample size. So a much wider confidence interval, but that one's going out to nearly a 30 times increased risk of dying from having that type of infection. This is my assessment of bias among all of these publications. And just for the legend, green is low risk, this is probably low risk, probably high risk, and high risk. And overall, I determined there was no substantial risk of bias affecting my evidence. I did see some issues with outcome assessment, and that's because most of the studies stopped after a month. And in reality, being exposed to an antibiotic, you've got a year of having an increased risk of having another infection. So a month did seem pretty short for them consistently, but we're still seeing that high of an effect within just a month. So we're also seeing that several of these studies were funded by pharmaceutical companies, and so there was high risk of bias in terms of sources of funding. And other things to note, confounding was controlled for by most of the studies, including things like having a recurrent UTI, a complicated UTI that involves anatomical abnormalities or pregnancy, diabetes. So overall, I found this no substantial risk. That feeds into rating the quality of the evidence. So other things, though, that I did have to note was that several of these studies, since people aren't necessarily asking this question, some of the studies were a little indirect. So they might have included pathogen E. coli and a different pathogen was included in the analysis, or they didn't, when they produced their numbers, they didn't separate hospital-acquired versus community-acquired. That was only 2 studies, but I did ding it for that. And then only 2 of the studies reported negative or insignificant findings, so I thought there might be some publication bias going on there. We definitely saw a large magnitude of effect, 1.85 to 7.76. And there was some evidence that residual confounding would have reduced the effect estimate. So ultimately, I determined that the rating of quality of evidence was moderate. In terms of rating the strength of the evidence, I found the evidence to be sufficient. So there is a positive relationship between susceptibility status of uncomplicated UTI and treatment failure, where chance, bias, and confounding can be ruled out with reasonable confidence. Now, looking at the costs, there were far fewer that were doing this, and I really think that has to do with the fact that with inpatients and hospital-acquired infections, there's a lot more incentive for a hospital to want to be cost-effective. But given that this is outpatient, it's just not, it wasn't as high a priority perhaps for many of these large hospital organizations to be doing research on this. But again, just seeing from these 2 studies here, resistant infections are significantly more expensive to treat by a lot. And if we look how these cost comparisons are being done, it's only the direct costs. And so these are associated with antibiotic acquisition, so the drug cost, and treating the primary infection, but then also the possibility of secondary infections. So actually, looking at it all together, only direct costs are being included. We're not seeing indirect costs, that's basically hospital administration was included in one. But things that were assigning monetary value to social costs, so lost productivity, they were not in the literature. And there was definitely no consideration of collateral damage, even in the form of a simple model that would include that antibiotic resistance is going to increase over time. So I want to make sure that this is cost effective, not just today, but 20 years from now. Is this still the cost effective decision? That was not present in any of the literature. So in summary of those findings, risk of treatment failure is greater in patients with resistant infections. It's associated with a delay in appropriate treatment, so getting the right antibiotic to treat you. And that causes increased length of stay, additional outpatient care, and increased costs. So direct costs were considered nearly exclusively, health economists only had this basic decision tree analysis to do. There were 3 studies of that. They all used the exact same model, and societal costs were not being included. So now, taking that all back to talking about empiric prescription and whether or not it is cost effective, knowing what we found from the literature review, I mean, I'm again just raising the question of whether or not this viewpoint is considering all the costs associated with empirically prescribing antibiotics. So actually, although they were not the primary outcomes, many of these studies had considerable adverse effects from the empirically prescribed antibiotics. So because of the delay in appropriate treatment, we saw that treating, there was a massive delay. I mean, half a day matters when it's a bloodstream infection. We're also seeing, one study they had 146 participants in the study, and 42 of those did not even have a bacterial infection, and they were prescribed these antibiotics. And out of those 42, 4 of them ended up with secondary infections, one of which cost $25,000 to treat, hospitalization. She basically had cleared out her gut's microbiome, a new pathogen took root, and she ended up in the hospital for 2 weeks. And so, thinking about diagnostic testing or directive treatment, after the fact, one study was looking at it and they said, for every 1 resistant infection that we're catching, we're having to test 23 people. And they said, well, that's not cost effective. But given everything else I've seen, I think it is. And moreover, the cost to do laboratory tests for all the patients in one study would have totaled $4,700. But because of those hospitalizations and secondary infections, it cost $35,000. So in terms of cost effectiveness, clearly the diagnostic costs are warranted. And one study actually changed their inclusion methods, which is very interesting because originally they were including people based on a dipstick test. And then they realized instead they were going to be doing symptom-based. And what we saw is that the number of people that were joining the study and getting antibiotics, we're looking at 83%. Actually had an infection, but with symptom alone, it was 70%. So 30% of the people in that study were getting antibiotics, but they weren't needing them. So the strengths of this systematic review, I did try to use PRISMA and the navigation guidelines to make sure it had the highest integrity. It was, from what I found, the first review of studies comparing treatment failure among resistant and susceptible E. coli for uncomplicated urinary tract infections. And it was really it's the only thing I've seen in my work, of course, that it had a public health lens to look at this question and think about collateral damage as an externality, the same way that you would with oil and gas, considering these other elements into the true cost. There were limitations. As a single reviewer, I may have entered bias into this through the inclusion process and when I was rating the strength of the evidence. And I didn't use all of the data or all the publications out there that were maybe doing this in a better lens, using those other features, because they were based on pneumonia and hospital-acquired infections, and I wanted to make sure my results were specific to this particular thing. And also the fact that because everyone used a different primary outcome, how comparative they really are is a question, but again, as they pointed out, it's almost a strength as well because then we see it across all of these treatment failure definitions, we're seeing consistent results. I'd like to acknowledge Dr. Price and Dr. Zoda for helping me through this process, as late as it may have been. Questions?
That was really, really interesting. And obviously you thought very carefully about these issues and navigated very nicely through the various studies. I wanted to ask you about the evaluating the risk of bias.
Mm-hmm.
And so you mentioned the potential limitation that it was just you making those determinations. So how might you have done it differently? What would be another way in order to negate what your own subjective appraisal was, and you could have reduced that? How might you have done it?
Sure, absolutely, and that was a big concern I had. Dr. Zoda had me, I was frantically on a phone call being like, what if I'm assessing it wrong? And I think that, you know, traditionally you'd have multiple reviewers, of course, and then you would do it independently and have consensus, discuss out things that were not consistent. And I didn't necessarily have that. And maybe if there had been more time, I could have roped Dr. Price into doing that with me. But what I found when I was worried about this issue is that I repeated the process. And I did it after, like the first time I had done it, you know, it was all new. And so doing it a little bit later after I had time to reflect and think, okay, I looked at all the study that I reviewed first versus the study that I reviewed last, there was probably some bias that first time. So going back and doing it again helped me, confirm, yes, I do believe that there is risk here, or no, actually, after reviewing all of them, I realized that's not as big a concern as I originally thought it was.
Great job, really interesting talk, and I thought you did a nice job of applying the navigation guide. Even, and acknowledging the parts that are more objective versus more subjective. So you rated the quality of evidence as moderate. Can you talk about a few things, a few specific improvements you would like to see in the next incarnation of studies on this topic?
Absolutely. I think the indirectness was one of the things. So, I wanted more studies to be there that were specifically about community-acquired UTIs. And because we were lumping in, the study's being conducted at a hospital, so you're including inpatients with outpatients, and they might have a criteria that says, well, someone who's been admitted within 24 hours, that's going to be a community-acquired UTI. And so I would like to see more that are conducted in outpatients all across the country, not just a single center, so that this evidence can be very specific to the types of community-acquired UTI and not in any way biased in terms of who's being included in that study.
Did she answer your question?
Oh.
That was a great presentation. It was starting with 600 articles and you really synthesized it down. I'm wondering, what are, speaking of questions, what are the next questions that you would want to answer? Could you sort of tell me a type of study that you would think would be helpful in answering that question?
Sure. I'd like to see a study that is not just comparing patients, but is comparing actual empiric prescription versus directive. I mean, that's really where we started with this project. That was the question we wanted to know. Nobody's looking at it. I mean, there was one that's using modeling that sort of compared that, but I think that's the real question, because what we need to find is the best way to treat this, the cheapest way and the safest way. And so no one was really looking at that particular question. There's just empirically prescribing, just like antibiotics for everyone. So that's what I'd like to see. Anyone else?
And how would you, did you answer
Oh.
that? How would you do that?
How do I do that? Well, I think it definitely needs to be a prospective design. Again, looking at outpatient centers all across the country, randomly assigning either this empiric prescription or some sort of using dipsticks or some sort of point of care test, and then also maybe the combination of the two, because it isn't just empiric prescription or directed treatment. There's also the option to use diagnostics so that you can correct if you need to. And so really figuring out what's the best strategy to keep people from getting kidney infections, for selecting multi-drug resistance, for ending up hospitalized. Really investigating all of those avenues to determine what truly works the best. Did I answer your question fully? Yeah. All right.